Right. Gallstones, all you need to know about it. Very simple, but pitfalls to be presented as well. Okay, this is a bit of anatomy for you to refresh you. It's very straightforward, actually. The gallbladder feeds into the common bile duct, which can therefore lead to a problem. Blood supply is very straightforward. We don't really know why it's there, actually. It's a bit like an appendix. If you remove a gallbladder, nothing much seems to change. So, patients often ask, well, if you take my gallbladder out, how will I digest fat? And it doesn't matter. Okay, let's go through the commonest symptoms. Right upper abdominal pain, nausea and vomiting. Now, all of you have seen lots of patients like that. And this is Boas sign. The pain radiates to the right scapular area. Irritation and innervation is similar for that area as it is for the liver and gallbladder. Remember that the gallbladder is actually part of the liver and originates from it. So those are the typical symptoms, all right? Let's just advance here. Now, slightly worse symptoms, jaundice. Jaundice usually implies either that you've got problem with the liver, and it's not a gallbladder that's the problem, but a hepatitis or something. But it can happen in gallstone disease, even if there's no stone in the common bile duct, because as the gallbladder gets inflamed, there's a lot of edema around it. It can just squish the common bile duct a little bit, and you get a bit of jaundice. You get a deep jaundice, you begin to think there is a complete obstruction of the bile duct. But patients usually present before that with a mild jaundice. Now, recurrent symptoms is very typical, so a lot of patients don't actually, certainly in my experience, don't go and see their doctor when they get their first symptoms, because it dies away very quickly. So if you ask them, they'll say, I've had this several times, but this attack is worse. It frequently occurs at night, and I won't bore you with the sort of ideas as to why it occurs at night, but it's not infrequent after fatty meals. So patients actually tell you they had fish and chips, rump steak fried in butter and double bacon as well, and then they get the symptoms. But they volunteer those, actually. Now, I've taken out fair because we've got a large Asian population in Hillingdon and Mount Vernon, but it was fair, fat, fertile, 40, okay, 40 plus. But certainly, they tend to be obese. You have to watch out. Gallstones aren't improbable in young women who are on the pill or had babies, so in the 20s. But in general, they're overweight. Fertile meaning had 3 or 4 children, because pregnancy causes biliary stasis and therefore formation of gallstones. And 40 plus. In general, that's quite true, because patients can tolerate the symptoms for some time, especially if you've got 3 or 4 toddlers walking around, you have a bit of abdominal pain, you don't go and see a doctor. So they present later. Okay, what are you going to find when you examine the patient? Well, in general, they can have right upper quadrant tenderness. Okay, not all of them have. If it's a mild attack, they won't have any physical signs. Guarding is not a great sign, because it means that when you press your hand in, it's that tender, it means that something is very inflamed. It doesn't have to be the gallbladder, and we'll come to that. But it means something's going on intra-abdominally, which is more than the average little bit of gallstone and cholecystitis. Pain is a given, and jaundice is a sign that if they haven't actually complained about their dark stools and yellowness, you will spot quite easily. I mean, normally, as you know, the bilirubin level is around, 12-ish or whatever, lower. And if it goes, what's the visual level that most people can see jaundice in the eyes? It's around 70 to 80. Certainly for me, it's 70 to 80. I don't know. Some people have got a very good idea. Okay, now, just why do you get jaundice? We'll go over it again. There's a gallstone blocking the common bile duct. You can see the position of the gallbladder. It's quite high in the abdomen. You're eliciting the signs below the rib cage, but actually the gallbladder is slightly higher than that. Okay, and this is why you get jaundice. And jaundice actually is more for surgical emergency, because all you're doing, if you delay it, is the bilirubin actually damages the kidney as well. So if you leave it 2 weeks, you're just destroying, nephrons. So it becomes much more for surgical emergency. Now, these 3 things are often forgotten. It's not the first time, it won't be the first time I've seen surgeons removing a gallbladder when patients had a myocardial infarction or appendicitis. If the appendix is behind the cecum, and there's quite a high incidence of that, and gets inflamed, you can get pain in your right upper quadrant. And it starts off as mild pain, it becomes worse, they get a fever. It looks just like cholecystitis. You can treat it with analgesics, send them home, but you always got to think about it. Is this not cholecystitis? Okay? And finally, hepatitis. Now, what do I mean by hepatitis? I mean, any inflammation of the liver. So it could be a proper hepatitis like hepatitis B, commonly hepatitis A. The liver gets a bit swollen and you get pain. And you've got to think about that when you've got, particularly when you've got some jaundice. All right, the lab tests. Now, you know, the first stage, if someone comes to you with very mild symptoms, you can do the blood test. How do you make a diagnosis after that? Because it can be normal. All right, the patient's symptoms may then go away. And then everything's forgotten. If the liver function tests are deranged, even slightly high bilirubin, that sort of thing, then you've got to decide that this is not nothing. This is something to do with the gallbladder, the liver, or whatever. And you need to really think about what you're going to do. A high white cell count, if it's not too high, it implies, yes, you've got an inflammation there. If it's very high, you can be going on towards things like an abscess in the gallbladder, which, the gallbladder gets full of pus. And that again becomes a surgical emergency. As I've said, a high bilirubin means that the gallbladder is inflamed or there's a stone in the duct. Okay? You can get, actually, somebody's asked me whether you get a high bilirubin with appendicitis. If you've got a lot of sepsis, yes, because it affects the liver and the excretion of bile. Okay, now how would you treat it in primary care? You really got to look at it. Mild symptoms, you think they're typical of gallbladder problems. Patient walks in, no problems with, they're walking pretty normally. Well, okay, you can give them some analgesia. If you think it's gallbladder, say avoid fatty foods, do the blood test, and do an ultrasound. The ultrasound may show gallstones, all right? Now, if I scanned everyone in this room, which I'm not going to do, 50% of you, if I'm looking at the age group, will have gallstones, which you may not know about. Does that mean I need to whip your gallbladder out? No. Does that mean that any pain you get in your tummy is due to your gallbladder? No. But we have to really think about, gallstones and the indications for surgery then. Now, referral to secondary care is either outpatient or inpatient via A&E. And who would you refer as an outpatient? Someone with recurrent symptoms. You've arranged an ultrasound, shows gallstones, sounds very much like gallstones, fine. You can arrange a planned outpatient appointment. Who do you refer as an inpatient? Patients who are jaundiced, patients who have very high white cell counts or a fever, and patients who are in severe pain. And all those groups really should be referred as an emergency rather than to an outpatient appointment which may be weeks away. Okay, now we go back to surgery. It's not always necessary. About 40% of patients I see with gallstones and reputed gallstone symptoms I don't operate on. Some of them are just elderly, had one attack of pain, which is probably typical of cholecystitis, but why remove it? If I had known gallstones and I had one episode of pain, which was resolved by analgesia and avoiding fatty foods, I wouldn't be walking into an operating theater, or wheeled into an operating theater, I should say. Beware the pitfalls, okay? Angina and a myocardial infarction can give you abdominal pain. All right, and just think, if the patient is getting atypical symptoms of cholecystitis and is getting symptoms that might fit in with angina, then you should really think, of this differential diagnosis. And I've covered appendicitis and hepatitis, but liver secondaries lead to tenderness in the right upper quadrant. You may feel a mass, you may think it's an enlarged gallbladder, but this is where the ultrasound comes into play. Right? We had a patient only last week who had 2 large liver secondaries. We still don't know the primary. He was admitted as acute cholecystitis, but you could feel the mass, and it's very tender, a large liver secondary. Okay, what are the bad things now? If a gallstone passes through the common bile duct, it's usually held up at the sphincter of Oddi where the pancreatic duct joins. If it's small enough to get there, it blocks the pancreatic drainage. You can get a raised amylase and pancreatitis. So then the whole thing changes a little bit. The patient can become jaundiced for the reason of obstruction. They get more central abdominal pain and they're sicker. But the raised amylase is always pretty typical, and that will give you the idea, not that they've just purely got pancreatitis, but it may be gallstone-related pancreatitis. But that patient just to be referred, because pancreatitis can be very nasty, and it's quite a high mortality actually from gallstone-related pancreatitis. This is one we caught. Okay, this is I'm not going to take you through the operation, but you take it in this thing. When you've taken the gallbladder out and divided this little basket, as it were, brings the gallbladder out through the hole you've made just below the umbilicus. Should we have removed that one? Well, there's the answer. This is it isn't produced very well, but full of gallstones. When the gallbladder is really diseased, you can sometimes get an indication of that on the ultrasound. The ultrasound will tell you thickened wall, that sort of thing. Then it needs to come out. But if it's a normal walled gallbladder, even if it's got quite a few stones, you have to really think about, the size of the stone doesn't really matter, nothing matters. And one of my colleagues who's a pathologist in the West Country, he says he finds huge stones in gallbladders and the patient's never had any problems. So, it doesn't mean that we as surgeons should be taking everything out. Okay, I'll go back one. Right.
Thank you.